Hi, welcome to PH Insights presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Hi, my name is Angela, and welcome to this inaugural episode of PH Insights. I am so excited to start this podcast and so lucky to have Dr. Jenny Yang with us today to kind of give us an overview of pulmonary hypertension. For those who are not familiar, for those who have a nuanced understanding of PH, hopefully Dr. Yang will be able to clear up some misconceptions for you. Dr. Yang, if you would like a moment to introduce yourself, please.
Sure. Thank you so much, Angela, for having me on this podcast. So, my name is Jenny Yang. I am currently an assistant professor of medicine at the University of California in San Diego. I finished my training in pulmonary and critical care fellowship back in 2021, and I've joined the faculty since then with a focus on pulmonary vascular diseases.
Thank you for being here. And I will just like to toot your horn for a second. We're so lucky to have Dr. Yang at our PH community workshop in San Diego. If you're not familiar, the Pulmonary Hypertension Association puts on regional workshops, educational opportunities in cities across the country. And we were in San Diego, I believe, last year or the year before last. So it was a great time. Thank you again for being a part of that. So we're just going to go ahead and jump right into this conversation today and really hopefully set that baseline of information to help people understand pulmonary hypertension. So Dr. Yang, just if I was newly diagnosed or, coming in because I have this suspicion, what is pulmonary hypertension?
Yeah, it's sort of a very common question that we get. So, pulmonary hypertension is high blood pressure in the pulmonary arteries. And so those are the main blood vessels in the lung. And this is separate from having high blood pressure in your body. And just because you have high blood pressure doesn't mean that you necessarily have pulmonary hypertension and vice versa. And so there are lots of different reasons why this pressure in the pulmonary arteries can be high. But to sort of first understand that and to get a better understanding, it helps to know the general circulation of blood between the heart and lungs. So, the
Mhm,
heart we think of as having two different sides, a right side and a left side. So,
mhm,
blood that returns from the body goes to the right side of the heart. The right side of the heart then pumps that blood to the lungs. The lungs will provide that blood oxygen, and then that blood then goes to the left side of the heart. And the left side of the heart then pumps the blood to the whole body. So, normally, the left side of the heart is a bigger muscle. It's a bigger size of the heart because it has to work a lot harder than the right side of the heart, which only has to
mhm,
pump blood to the lungs. But there are certain situations in which the right side of the heart has to work a little bit harder and it has to generate more pressure to get the blood from the right side of the heart into the lungs. And when the pressure that the right side of the heart generates is over a certain amount, then we call that pulmonary hypertension. So currently the definition is specifically a mean pulmonary artery pressure of over 20, but there's all different sort of reasons why that can happen and we classify them in general in five different groups of pulmonary hypertension.
This is completely different than if you just have that diagnosis of like hypertension, right?
Correct. Correct. Yeah. Having that diagnosis of hypertension or high blood pressure is separate from having pulmonary hypertension, which specifically is affecting the blood vessels in the lungs, even though they use the same words.
And then you also mentioned classification. So I've heard this multiple times. And again, for our audience, what are these different classifications you were describing?
Yeah, so there's five different general classifications for pulmonary hypertension. And so I can go a little bit more into each one of them. So the first group of pulmonary hypertension, this is what we call pulmonary arterial hypertension or PAH. And this is a very specific disease process in which the pulmonary arteries become thicker. And this happens for a variety of reasons. There are several other conditions that can be associated with developing PAH, and these include things such as connective tissue diseases, HIV. There's certain congenital heart diseases or drugs and toxins that can all lead to this process where the pulmonary arteries get
Mhm.
thicker and stiffer. This can also happen for unclear reasons sometimes as well. But this is the group of pulmonary hypertension that, if you were to Google it, you see a lot of research out there, and there's a lot of
Mhm,
medications specifically for this group of pulmonary hypertension. But it's not the most common group of pulmonary hypertension. So the next group, it's sort of our second classification of pulmonary hypertension. This is, pulmonary hypertension that's related to issues with the left side of the heart. And this is the most common cause of pulmonary hypertension. And that's purely because of the prevalence of heart disease in this
mhm,
country. So if there are issues with the left side of the heart, issues with the heart pumping or relaxing, or if some of the valves in the heart are a little bit leaky or stiffer, it can cause the pressure to be higher and get reflected back on the right side of the heart. And so this is the second group of pulmonary hypertension. The third group that we have is pulmonary hypertension related to lung diseases. And so this can be scarring in the lungs or various other lung diseases related to smoking or other exposures. And this occurs because the lungs themselves are stiff or damaged. So the right side of the heart has to work a little bit harder to get that blood into the stiff or damaged lungs. The fourth group of pulmonary hypertension is related to blood clots or tumors within the blood vessels themselves. When it's related to blood clots, it's something that we call chronic thromboembolic pulmonary hypertension, or CTUF for short.
mhm.
And it can also occur with certain cancers or tumors that grow within the pulmonary arteries. And then the last group of pulmonary hypertension is sort of this grab bag of miscellaneous things where we don't
Mhm.
really understand the mechanism of how pH develops. And so these are things such as sarcoid or sickle cell anemia, various other diseases as well that can lead to pulmonary hypertension, but we don't have a great understanding of why that is.
So, with these various classifications, and we'll get into this in a little bit later, but if I come in and I am showing symptoms, which we'll also get to, and okay, you have pulmonary hypertension, do you then go in to identify which classification I have? And why is it important for me to understand or know which classification I may have of pH?
Yeah, it's a great question. And it's, really important to us to try to figure out what classification of pulmonary hypertension someone has because it will determine our management.
Okay.
Each of these groups of pH are treated slightly differently. And so we want to make sure that we find the best treatment for each patient. And that first depends on knowing what type of pH someone has.
So with that, you also in the classifications mentioned smoking or sickle cell anemia, sleep apnea. How do we break down or understand the cause, the root cause of why I am showing up with pH in your clinic today? How will we get to understanding of the cause of pH for me?
A lot of that is, during the clinic visit, we ask a lot of different questions about various risk factors that may predispose someone to
Mhm.
a certain type of pulmonary hypertension. And so that includes a history potentially of clotting disorders. If someone was a heavy, long-time smoker, that increases their risk of having certain lung diseases. But then, sort of beyond the various questions that we ask, there's also certain testing that we'll do. And some of those tests help to place these patients into different classifications of pH or at least rule it out. So that way we can try to rule out various causes of pH while we're trying to determine what type of pH they have.
So just within working in,
Mhm.
this field and working with PHA, I know of idiopathic, heritable. Can you break down what those terms mean?
Idiopathic. This is the most common type of pulmonary arterial hypertension, actually. It means that we don't know why someone has pulmonary arterial hypertension. This is, most common in young women,
Mm.
typically in their 20s to 40s or so. There's a lot of research going into sort of why, young women tend to be at higher risk for getting PAH. But the label idiopathic means that there were no other risk factors identified or other causes identified for why they have PAH. Heritable means that it is runs in the family. So there are
Mm.
certain genetic mutations that have been associated with PAH. And especially if there's a strong family history of PAH, then patients may hear the term heritable PAH as being the cause for why they have it.
So you mentioned idiopathic is the most common for young women specifically. Regardless of their classification, what are some symptoms someone should look for or they may experience when navigating this?
Yeah, so the most common symptom that we hear of is shortness of breath. And this is, it typically tends to first show up when they're doing activity or exercising. They may notice that they're getting a little winded more easily, or on walks, they can't keep up with their peers. That tends to be the first and most common symptom that we hear. The other symptoms are also fairly vague and nonspecific. So this includes things like fatigue, palpitations, or feeling like your heart is racing. Some patients will get swelling in their legs. You can also get swelling in your belly area, and that can make you feel full more easily. So patients may not be eating as much or have a poor appetite, gaining weight because of all the fluid retention. Chest discomfort is rare but can also occur, and some light, especially with bending over or doing a lot of activity. But, that's one of because these symptoms tend to be so sort of non-specific, but be a hard thing to diagnose because, not pulmonary hypertension doesn't always come to mind at the top of the list with those symptoms.
Not at all. What is that diagnostic process?
So there's, because these symptoms are so vague, a lot of times, patients may get various tests before pulmonary hypertension comes to mind. One of the more common tests that is done that first will suggest the diagnosis of pulmonary hypertension is something called an echocardiogram. And so this is an ultrasound of the heart. And by doing that, we can take a look at the size and the function of the right side of the heart as well as the left side of the heart, but we can also get an estimated pressure of how much pressure the right side of the heart is generating or working against. And if that pressure is high, or if the right side of the heart is big and more dilated than normal, that can be suggestive of pulmonary hypertension. So that often tends to be the first test that will suggest the diagnosis. Um,
I'm sorry. I didn't mean to interrupt, but I mean, it's fascinating that it may not even be on your radar as something you could have an issue with. So are there any challenges? Like you mentioned, obviously some of these symptoms are very vague, like they could be, just you're winded at that certain time. Are there any challenges or things you would want our listeners to know as far as receiving a diagnosis?
yeah, I think that, receiving that initial diagnosis can be, quite a journey for some patients because they get, a lot of the common tests that we do for these symptoms of shortness of breath are specifically looking for other issues within the lungs. So you might undergo things like breathing tests or chest x-rays or CT scans, which can all be normal. But patients are still feeling short of breath and clearly something is wrong. And I think it's important to continue to try and, advocate for yourself and, try to get to a PH center
Mhm.
where they have a better understanding of pulmonary hypertension and potentially doing other testing that can confirm the diagnosis. Because there are also certain cases where the echo may look normal, but people with risk factors for PAH, might still be sort of at risk for getting pulmonary arterial hypertension, and it just hasn't shown up yet on some of these early testings.
Yeah, I think that's important. You mentioned going to a pH center specifically. A lot of time it's especially if you are now struggling to breathe and you are feeling chest pains, you may go to the emergency room. It's not always the case that they may understand, pulmonary hypertension in the emergency room. So being able to reach out to a center is very, very important for your treatment. Can someone just call up a center? Or do they need a referral from that emergency room doctor or their primary care? How does that work?
I am not sure with in terms of sort of other centers. For for our center, they do need a referral. It can be from anyone, from a primary doctor, from the emergency room. Some patients have chosen to try and self-refer, and depending on their insurance, we can,
Mhm.
we're always happy to sort of see anyone with these sort of complaints. But I think many centers probably need some referral from either their primary doctor or another provider.
And I will add here that we do also have PH care centers. So PHA supports care centers across the United States. And these have gone through like a rigorous accreditation process to really understand and care for a patient showing up with PH. We do have that information listed on our website. So you can visit phassociation.org to find a care center in your area. So we've gone through an overview of pH and understanding the various classifications, who's at risk, the risk factors that contribute. What about treatment options? You mentioned Googled earlier, and I know, I get a lot of phone calls from patients who are Googling, and it's just what they see on Google is not what we want to typically share with them. We hope to direct them to good resources that inspire hope. So treatment or cures or what does that look like? Medication. How can people live long with PH?
Yeah. So treatment options will vary across the different classifications of pH. Briefly, just to touch on some of the other groups of pH, where the pulmonary hypertension related to the left heart disease, the focus is really on treating the underlying heart disease. And so whether that's certain medications for heart failure or addressing any valve issues, but giving specific pulmonary hypertension therapies to this group can potentially be harmful. So we focus on treating the left heart disease. And same thing for the pulmonary hypertension related to lung disease. The focus is really on trying to treat the underlying lung disease with inhalers or oxygen if needed. There is a specific medication that we can use in this group, and it's an inhaled, sort of nebulized medication if the pulmonary hypertension is related to scarring within the lungs. And for the fourth group of pulmonary hypertension, which is related to those chronic blood clots or CTEPH, the treatment here is actually vastly different. It includes potentially a surgery or a interventional procedure in the cath lab. And so the surgery is an open heart surgery. And then the other potential procedure is something called pulmonary angioplasty, in which we sort of remove or try to restore blood flow by disrupting the blood clots within the lungs. With the last group of pulmonary hypertension, there isn't any great treatment options since we don't quite understand the underlying mechanism of how the pH is developing. But, sort of for the main type of pulmonary hypertension that we, want to discuss, which is pulmonary arterial hypertension, you have various medications that we can use to treat this. And so these medications are, in general, they work on three different pathways. And all of these different pathways serve to relax and dilate the blood vessels in the lungs. And so these three general pathways, the first one is called the nitric oxide pathway, and the medications in this pathway are serving to help to relax the muscles within the pulmonary arteries.
Okay.
There's another pathway called the endothelin receptor pathway. And so we also have a group of medications that work on this pathway that will also serve to help relax the pulmonary arteries. And then the last pathway is called the prostacyclin pathway, and it similarly works to help dilate the blood vessels in the pulmonary arteries. And so we like to combine medications from these different pathways. So, in general, most patients will be started on at least two medications initially, one from each pathway. And so, in the past, the most number of medications that a patient could be on was three. These these medications can be given also through different mechanisms. So many of them are pills that are taken once or twice a day.
Mm.
Then we also have inhaled drugs. We have ones as well that are given through an IV or under the skin continuously. And so for these continuous drugs, it requires a pump that patients have to carry with them 24 hours a day, 7 days a week.
Okay.
Definitely a big change in lifestyle and requires a lot of education and resources up front because it patients will have to have many of them a central line to
Mm.
get intravenous medications continuously. But they are very effective medications and can improve quality of life and help patients able to sort of continue living their life. And then just, more recently, sort of within the last few months, there's
Mhm.
been a new drug that's been approved for pulmonary arterial hypertension that works
Mhm.
on a completely different pathway. And so it's, very exciting. It's, there's been lots of research, and clinical trials looking into this medication, but this one
Mhm.
is also given via a different mechanism. It's an injection under the skin that's given every 3 weeks. So as of just a few months ago, now there are patients that can be up to 4 medications for pulmonary arterial hypertension.
But is that rare? Is that always the case? Or some patients available to get that drug or approved, not available, I'm sorry, to get that versus others? Is that something that's open to any patient with PAH?
It is available now, I think, for all patients with PAH. Whether or not it is needed is
No.
still, is a sort of ongoing discussion. I
Mm.
think, there will be lots sort of to come in the next few months as to when we should consider starting this medication. We've known for many years, based on some of our older studies, that the medications that we have are very effective and good. And so we don't wanna necessarily risk going with the new medication in place of the ones that we know are effective.
Because just like with any medication, whether it's new or something that's being utilized, there are side effects that can happen. I'm sure there's a process to figure out the best combination for a patient based on those side effects. And I think I asked this in other, we have webinars, we have all kinds of ways that people receive information. But should your patients, if they're taking a medication, always share, the side effects they're experiencing with their team, with you?
Yes, we always want to hear about any side effects or, that you're experiencing, whether you've been on the drugs for pulmonary hypertension for just a few days, a few weeks, or months. We always want to know about any symptoms that someone's experiencing. We also like to know if you're starting new medications,
Mhm.
even if they are like herbal supplements, because there are interactions that can occur with some of our drugs that we give, and there are also things that can make the pulmonary hypertension potentially worse. And so we always like to know about side effects as well as any new medications or new supplements that someone's taking.
So always share with your healthcare team if you want to add something else into the mix or if there's another situation that requires medication.
Yeah, we always like to know if about these new medications. As part of our pulmonary hypertension team, we also have a pharmacist who is, her job is to sort of review all the medications and make sure that there aren't any interactions with new medications that come up. And so anytime there's something new being sort of mixed in, we
Yeah.
definitely want to know about it. And, while we're always open to talking to other providers, and if there is a potential interaction, coming up with an alternative solution that works out best for everyone.
So, like I mentioned, Dr. Yang was a co chair for our San Diego workshop. And one of the slides you talked about like further management of PAH, and that included a couple of options and things recommended, suggested to bring back to a patient's team. Can you kind of go back into a little bit of the management of PAH, please?
Yeah, in addition to just the PAH medications, there's definitely a lot of, health maintenance things that we want to continue, during the care of our PAH patients. And so some clinic visits usually every 3 to 4 months to start out, and then potentially going out to 6 months if patients are relatively stable. And, these clinic visits are important to, basically just to check in and see, are they having any side effects from their new medications? Are they getting new symptoms? Are
Mhm.
they starting to retain more fluid? Do we need to make any adjustments in their diuretics to try and help? The goal is to prevent them from getting worse by being proactive and seeing them, every 3 to 4 months to make sure we maintain them in a good spot and prevent that decline. And some of the tests that we'll do during these clinic visits or as part of the monitoring. So, one is a 6-minute walk distance, and
Mhm.
usually at least once a year. And that gives us a good sort of idea or trend of how patients are doing in terms of their exercise capacity. We like to see that they are sort of steadily improving or at least stable and not declining in their 6-minute walk distance. We may also get echoes yearly to check on their right side of the heart and check on the pressures to make sure that things are remaining stable as well. And then, other sort of general maintenance items are also important. We encourage them to exercise and do activity. Sometimes, pulmonary rehab can be very helpful in improving their exercise capacity. Um, Eating healthy and getting routine vaccinations are all sort of important general measures as well. But, as part of these clinic visits and, we sort of will get that assessment to see how they're doing. And if there's concern that despite our maximum number of medications that we have for PAH, things are declining or worsening, it's
Mhm.
important to sort of reach out to potentially or to discuss lung transplant as
Okay.
a possibility. There is no cure for PAH at this point. It is a chronic progressive disease.
Mm.
And our goal with treating is to, to slow that decline and help improve symptoms. But we know that in general, this disease will continue to progress. And so, if it gets to the point where things are severe despite our maximum medications that we have, we have a close relationship with our lung transplant team here, and we'll get our patients in to see them and discuss if they are potentially a transplant candidate.
Mhm.
We also have lots of sort of active research clinical trials that our patients, can participate in to try and help find the next therapy or see if there's something else that may benefit them. And then, of course, throughout this all, PAH is a rare disease. And so,
Right.
having that support is really important. So,
Mm.
support groups, which I know PHA has a lot of, finding that community of, other people who are going through similar things is just as important to, to find that bond.
Yeah, thank you for that. PHA does offer a lot of opportunities to connect through support groups, whether that is in person, virtually. We also support groups on Facebook as well. There are many options to connect, whether it's parents, teens, young adults. You can visit phassociation.org/support to get more information on that. And real quickly, while I still have you, you did mention clinical trials. I know, like, hearing clinical trials, people get scared. Is there anything you can, say to those listening to kind of ease those fears?
Yeah, I think, yeah, clinical trials, I think, are a really important part of PAH, but that word, trials and research is
Mhm.
always scary when you're talking about your own healthcare. And, but, I will say that we do a lot of investigation into these research clinical trials
Mhm.
to before we decide to participate in them to really make sure that these are worthwhile for our patients. We also, don't want to put our patients in a trial that we think is not going to be an effective trial. And these are important components of trying to find the next therapy in PAH, whether that could potentially be a cure down the road. It requires sort of a lot of research and sort of investigation to try and get there. And the clinical trials that, that we do participate in have been studied sort of heavily already by the before the time they get to the place where we're participating in them. And we are, very open to sort of always discussing the risks and benefits of participating in these trials with our patients. And, just because someone participates in one does not mean that they are locked in. If there
Mhm.
are any hesitations down the road, they can always withdraw their consent, and it does not affect their care by their PH provider in any way. And it's, offered as hopefully an additional therapy that we don't yet have to offer besides the current medications.
Yeah, I think it's very important. We'll definitely have to do an episode on clinical trials just to share that information and kind of ease those fears that people hear when they hear, like you said, trials and research. Um, the I want this to be a space for hope, a space to, allow people to feel comfortable advocating for yourself, as you mentioned at the top of the call, and being able to connect to their healthcare team. Do you have any words for those listening who are scared to ask questions to their team or unsure where to start?
I think it's, PAH is, such a rare disease, and
Mhm,
I think it's definitely important to advocate for yourself. It can be difficult and scary to bring things up to a provider, especially if you're meeting them for the first time. And I
mhm,
think that is where, a lot of patients can draw support from their community. People that have been living with PAH for years and years can
mhm.
be a really great resource for you to find that confidence and, knowing what to ask and to really help them build that relationship with your provider. But I can't emphasize that, those support groups enough because I think it really has helped a lot of our patients who are newly diagnosed and trying to,
Mhm.
go through this journey, which is really scary. And doing it alone is that much more scarier. And finding those resources in these support groups can be really helpful. When your PH team is, you can feel free always to ask us anything.
Mhm.
There's no question that we haven't heard, and we are always, more than welcome to answer anything, even if you think it, is, a terrible question. We're always happy to hear it, and we'll offer our insights and advice. And we have a team of nurses and pharmacists who are also here to help answer everything.
Thank you. I couldn't have said it better myself. I will leave on that note. Thank you so much, Dr. Yang. It was such a pleasure having you on this very first episode. I know we've been talking about this for a minute, but I appreciate you joining me today to share this information. Thank you so much.
Thank you so much for having me. It's been great, and I know it's been a long time coming, so I'm really
Yes.
excited that we finally got to do this.
Yes, me too. And thanks everyone for listening to PH Insights presented by the Pulmonary Hypertension Association. Remember, subscribe and join us every second and fourth Wednesday of the month for more valuable insights. We'll talk to you soon. Thank you for listening to this episode of PH Insights. We like to take a moment to thank our sponsors for their support of the PHA Connects program, which brings you the PH Insights podcast. Sponsors do not participate in the development of and do not endorse content of programming. For a list of our 2024 sponsors, please visit our website at phassociation.org/aboutph/sponsors. Thank you for listening.